Let's get started. So my name's Rob Morlino. I work on the executive committee for the ENACT network. I work at Pitt and help run marketing communications. This might be the first time you've seen me moderating this. Today we have a great guest, Dr. Thomas Kannampallil from the University of Washington, and we're going to get into a more complete introduction of him in just a second. Want to just let you know that Grand Rounds is a monthly seminar series provided by the ENACT network here. We cover all sorts of topics to best leverage real-world data and generate real-world evidence. We will be studying everything from EHR to cohort discovery to natural language processing. Clinical concierge service is our next session in April. We'll do a little plug into that at the end of this session if we have a bit of time. But please, if you haven't already registered, if you follow the link that you use to get here, the next couple of sessions you should be able to register for there. You're not obligated, but if you register for them, you'll get our reminders and stuff. The kind of order of business today is this introduction, and then Dr. Kannampallil will give us a presentation. We'll leave about 10 minutes for questions and answers, but you can drop your questions in the chat and I'll take note of them. And if they're really urgent or on topic, kind of try to interrupt and get them in there. Otherwise, we'll leave them towards the end. And lastly, I'll just give you some information about further sessions. So settle in. And please leave any notes that you have in the chat. So without further ado, hold on. Today we're tackling an urgent topic in clinical informatics, the adoption and implementation of artificial intelligence in healthcare. And while there's a significant enthusiasm and readiness around those clinical AI tools, the reality is more nuanced, and that's what we're here to explore a little bit. Dr. Thomas Kannampallil from the University of Washington School of Medicine is visiting us. He is the Chief Data Scientist and Assistant Dean for Data Science at WashU Medicine and an Associate Professor of Anesthesiology and Computer Science. His research sits at the intersection of computer science, cognitive science, and clinical informatics with a particular focus on implementing AI applications at point of care and using pragmatic clinical trials to evaluate digital health innovations, which is all my marketing speak to say that he's an expert in the field. He did let me know at the beginning, which I think is really reassuring, that the talk that he plans to give right now is less about really esoteric science of AI implementation and more about lessons learned so far, which is, I think, a lot of what we'd like to hear because the future is so nebulous in this regard. So I will stop sharing, and Dr. Kannampallil, are you all set to go?
Thank you, Rob. Thank you again for inviting me. I'm Thomas Kannampallil. I'm at WashU Medicine. Not at the University of Washington, just to correct. I'm at WashU in St. Louis. Just wanted to give a little bit of a background than what just Rob said. I'm an associate professor of anesthesiology and computer science. I'm neither an anesthesiologist or a computer scientist. I'm a clinical informatician by training. And most of what I'm going to talk today is broadly about sort of things you might already know, things you might think about, but more on sort of the pragmatic side of implementing AI, sort of the challenges around it, what considerations to take, and some of our experiences in implementing some of these AI tools. So some research disclosures. Most of these, I'll talk about some of the research grants, but I'm a deputy editor for Elsevier Journal. I will also say, just as of last month, I did not forget to put it here, apologies for that. I'm also on the National Research Council for Abridge, the ambient AI scribe. It's an unpaid position, but still, I felt like I should say that. So with that, broadly, if you haven't heard about AI today, everybody must be living under a rock. It's supposed to solve every problem that we have. potentially solving pragmatic issues in the real world, also providing solutions to in medicine, from drug discovery to genetic engineering to sort of novel frontiers in medicine. And even if you look at sort of the press, there wouldn't be this is just a set of clippings from New York Times in the last um, few months. There isn't a day in a New York Times editorial or an article that doesn't cover artificial intelligence, growing from scary parts of AI, sort of the considerations of ethics around it, are also very pragmatic uses in which it has been used. And if you've not been aware, it's been used everywhere from basic tasks to finding information to international war planning and strategy. So its use is pretty broad, and we've heard a lot about it. But today, what I'm going to talk about is much more focused on healthcare. And what I'm going to do for the next, I want to say 40 minutes or so, is to provide some aphorisms about things that I have learned, borrowed from others mostly, trying to situate what AI means in the current milieu where we're trying to implement it within the healthcare environment. And as I said before, please feel free to interrupt me in between. I can't monitor the chat, so if there are questions, please feel free to interrupt me during the process.
Absolutely. Thanks.
All right, so let me just make sure this goes to the side. Can you guys still see my screen? It feels like.
We can. We see a quote from Sam Altman.
Okay, Sam Altman. A purpose to start from Sam Altman. He's a local from St. Louis. He went to high school. My daughter goes to school too now. He left for Stanford, but he's considered now, a pioneer with his OpenAI development efforts. But this code was particularly the first part of this code, which Sam Altman gave us, particularly interesting to me. When he came out with the newer version, I think it was 5 GPT version 5. He said he was talking about how Meta and other organizations were poaching people from across the board in order to build their artificial intelligence tools. So his quote was basically, most of AI development is mercenary, but OpenAI is focused on sort of a missionary purpose, and his essential argument was missionaries will beat mercenaries. But this again goes back to the purpose that I want to situate this entire talk. Um, Technology is changing fast, and we're in the midst of this rapid change, a rapid set of interventions that people are developing. But we have to keep central to that process the missionary focus of healthcare. And it's not just about creating an efficiency or saving money or creating outcomes alone. It's towards this missionary focus. And I'll come back to this concept of this missionary concept in healthcare and why it's important when we consider these different interventions over a period of time. The second code, this is one of my favorite codes. Edward Wilson was a Harvard a sociobiologist who was asked the question, what's the problem with humanity? And he sort of answered it in a very broad sense, and I think it's very insightful. His answer was, humans have Paleolithic emotions, medieval institutions, and godlike technologies. And what he meant by that is that, human emotional and cognitive abilities have not changed in millions of years of evolution. Our institutions, be it hospitals or health systems, have or universities, have very medieval sort of structures attached to it, and making changes are very slow. But the technology that is being used in several of these institutions are changing at the speed of light, so to speak. The new versions of AI or large language models come out every 3 to 4 months, and the requirements that are required to keep up with these technologies also changing so fast that it is almost impossible without consideration. So, for example, when we think of these sort of godlike technologies like AI, such as AI, there's cost considerations. What are sort of the things we need to consider when integrating with existing systems? How do we think about changing the workflows, sort of the training that is required when the technology changes, and sort of the broader perspective of the transparencies and sort of the biases that are potentially incorporated with these systems. So fundamentally, while the technology in itself is potentially excellent for a number of reasons, it also, you have to consider the sort of the socio-technical structures that are incorporated within the health systems with that missionary focus that I started with when we try to think about these systems. So, we have to understand that this is not just the technology alone, but the entire system within which the systems are within which these systems are implemented. That's one of my favorite quotes. So boiled water makes eggs hard and potatoes soft. So essentially, the idea here is that within these large health systems, there's a number of things that fundamentally affect behaviors and actions and how decisions are made. So, for example, decision-making processes in a health system or a health setting or a unit changes is very different. It depends on the expertise of the individual being involved. So, for example, a resident versus an attending physician with 25 years of experience, the decision-making processes change. It also differs from an outpatient setting to an inpatient setting. It differs from and not just the expertise, but what the sort of background and the training that the physician or the clinician involved has. It also depends on the interfaces with which they're in which they work in the right context where the decision-making processes are supported. So, in broadly, if you think about these sort of factors, the context matters in which the decisions are made. So with respect to AI-based technologies and AI-based assistants, there is a considerable heterogeneity in terms of what AI or how AI support should be provided and could be beneficial in these settings. So, this paper is now about a year old, I think, and essentially looked at how various factors with respect to the context affected the impact of AI assistance in I think in this case it was imaging on imaging data. So the how the errors happen, what the expertise of the physicians were potentially affecting the outcomes. Sure, several of you have seen these papers. There's this study. This was a randomized controlled trial of BI-RADS suggestions on reader performance in radiology. So the idea while the tool actually improved overall performance, there's automation biased across all groups. While in reading mammograms, the bias was seen among inexperienced, among moderately experienced, and also even very experienced radiologists, depending on a number of factors associated with how the images were presented. So this essentially puts us in this framework of thinking about what actually affects human behavior with the use of such technologies, such that the context in which these decisions are made, in addition to individual sort of characteristics that affect the decision making. I'll pause for a second. I can't see the chat, so.
No pertinent questions in the chat just yet.
Okay. All right. I'll go to the next one. And feel free to stop me in between. And now I'm going from this idea of the context matters, but also what's the impact of these sort of tools in human decision making. So, when the EHRs came out, one of the biggest concerns that were raised, and this is early 2000s, was that because of the amount of information that is presented on the screen, people are going to have what's called a poverty of attention, leading to multitasking and errors in decision making and challenges in decision making. And what we have now with these sort of tools, and this you're seeing more and more of these the biases, for example, that I explained earlier, we're going from a poverty of attention to potentially a poverty of imagination. And what do I mean by poverty of imagination? I don't know if folks have seen the study. I don't think this is published yet, but it's publicly available in MIT. Uh, uh, um, I think it was the media studies group. But what they did was this very simple study with EEG markers. They were given a set of folks, I think 40 people, aged 18 to 40, and they were given an essay writing task similar to a college essay. And these three groups, and they were separated into three groups. One group was asked to follow just the normal process they would follow. The second group was given ChatGPT and used prompting in order to create their essay. I think it was an SAT essay, not a college essay. But anyway, short essays. And the third group was given some tools to write, like Google Doc, and with some initial support. And the results, and this has been replicated in other studies, not really related to essay writing, but similar types of studies. And what they found was they came up with this concept called cognitive debt. And they found that the folks who used ChatGPT had potentially different rewiring of their brain when they were doing these tasks based on the EEG markers. Essentially, the argument that the authors were making is that AI offers immediate advantages, but it potentially reduces the sort of the cognitive effort that is required for potentially critical thinking, for reasoning about specific types of tasks, or maybe even developing independent thought, which actually affects long-term outcomes with respect to critical thinking and processing. So again, this is a single study. The argument that was made was essentially that these sort of tools, which while providing support and reducing the burden of actually performing the task, it potentially reduces the cognitive capacities over a longer period of time. Again, lots of limitations of the study. The study was a really small sample study with just EEG markers for a small scale. So again, the long-term implications of this are yet to be determined. But clearly, there is an impact of using these sort of tools where you're essentially offloading the cognitive effort to an external tool, which is able to provide you that initial support. Don't know if folks have seen this study. This was published about six months ago in Lancet Hepatology. So this was essentially a reanalysis of a randomized controlled trial. It was a four-arm trial, one part of which was done in Poland. So the essential argument, it was just to explain a little bit about the study. People were given this AI-based tool for adenoma detection during endoscopy, and they were essentially asked to mark the detection rate, in using the AI tool. The way in which the study was run is that some days they got the tool and the other days they did not get the tool. So it was the days in which they received the AI support was randomized. So what they found is that the continuous exposure to these sort of tools led to sort of a de-skilling of a task, because when they did not have it, the ADR rate actually decreased by 6% in non-AI assisted colonoscopy, which is kind of surprising. I will say it's still an observational study because it was a reanalysis of an existing RCT. Having said that, it does provide at least some direction in terms of how we think about the sort of de-skilling, potential effects of de-skilling on continuous exposure and the critical thinking aspects that I explained a little bit ago. So, in other words, what we see here is the potential expansion of this idea of the poverty of imagination, which has potential implications for both training in terms of clinical judgment, in terms of expanding some of these training and experience skills.
Thomas, we do have one relevant good question in the chat from Daniel about the previous study you cited that was exactly this one about cognitive debt. Daniel writes, if AI reduced the cognitive load for participants in a short-term task, isn't that the desired outcome? I don't see how this is an implication for long-term use of critical thinking. And I agree. And Daniel, you can come off mute. I don't need to,
Yeah.
preempt. But I was wondering a similar thing, and not to make a kind of um, layperson's comparison and spoiler for the film Wall-E that came out, I don't know,
Yeah.
15 years ago. But at the end of that movie, AI has taken over so many mundane menial tasks for people that they've just kind of turned into blobs. And that was, I mean, my own sort of
Oh, I don't disagree with that at all.
okay. And
I'll let Daniel ask his question and then I
sure,
can respond.
sure.
Yeah, no, I did ask my question. I just I absolutely agree that if you have a stupid system that people take their hands off the wheel and let the stupid system take over, then we all get dumber. I think that that's obvious. But
Yeah.
if we have a smart system that's better than us and we take our hands off the wheel and we apply our brains to something else, I don't understand
It's
why that means that we're getting dumber.
I
And if the argument is, well, if you stop thinking about this thing that you've been thinking about for your whole career, you obviously won't think anymore. Where does that come from?
Yeah, and I think it's a fair argument. I think the implication of this is not from for an experienced attending physician who is trying to do a certain task. It's more from the argument about training. So, for example, if you don't know how to write a note, for example, or listen to a patient, compress the information, or get the information, create a note, and you have an AI tool that writes a note for you, you don't have the ability, you potentially don't develop the ability and you've never done that part of the task, the critical thinking task before. There are potential questions about how these sort of tools can be incorporated in the training process, such that the trainees or the sort of the training process can be more incorporated. I think I don't think the question is that, yeah, if you can take your cognitive load out of a specific task that's mundane and not necessary, the argument is not to do that. The argument is more, what does the dependence on these sort of tools have an implication on sort of downstream impact on people's abilities to perform certain tasks?
Well, so how is that different from like, should people be allowed to touch calculators?
Uh, I don't. Are you saying that, like, for example, people shouldn't be using is that the
Yeah,
correct
no, I mean,
question?
once calculators came out, then all this like long division and memorizing your
Sure,
multiplication tables, it
sure.
all goes out the door.
I
We're not
don't, I
thinking
don't, I
anymore.
don't, I don't, I'm not disagreeing with the fact that some of these tools have implications for that. But the question is, do we know whether some of these tools um, reduce the ability for specific kinds of tasks that people may need to do in certain circumstances? I don't think there is I honestly don't think that there is a clear demarcation of what specifically is right or what specifically is wrong within this context.
That's great. We have another question by David. David, this is a great question, a little more general. Maybe we'll leave it till the end if that's all right with you, David. So please go ahead. Okay, it's giving us the
All right,
thumbs up, so please go ahead.
all right, all right. So that also brings up to this question of what is the role in a clinician AI type of collaborative enterprise? Is it a clinician AI collaborative task, which has been historically what these sort of tools have been imagined to be, or is there a role separation that can potentially be considered? So, the historical framing of the human AI collaboration has been conceived primarily as a sort of a mix, what Eric Horvitz from Microsoft conceived as a mixed initiative model. The human does some things, the AI, and it's a collaborative process in which these things work together. And sort of the classic example of that, for those who are old enough to remember, was the Project Lumiere, the sort of the Clippy project, or the Project Lumiere from Microsoft in the late 90s, which essentially was the idea that the human, a Bayesian belief net in the background potentially predicted what the user was doing, is going to give it suggestions. The reason why the Clippy didn't work, there's lots of reasons for that, but fundamentally the idea was sort of an assistive model. The assistive model essentially had two sort of issues. One is the idea of automation neglect, which is ignoring the right suggestions, and also automation bias, like not validating the sort of the wrong suggestions that happen. The other extreme, which Eric Topol wrote in this essay in New York Times about now almost a year ago, was that is there clearly a role separation, which is, I think, the question Daniel was asking. Is there certain things that the robot can do in itself, right? The machine can do itself such that you don't need a support structure to do it. So, for example, maybe taking like an ambient AI scribe, taking notes is something the AI tools do really well, offloading the cognitive effort that's not required in order to listen and parse and get the summary of the conversation. And the idea of this role separation framework, extending from that paper, from that editorial, was essentially two things: let AI do things that it does best, example, assessing low-risk cases, and potentially not requiring any sort of human insight, and doing the harder cases, whatever that harder means in the context, to the physician, such that those cases are handled with respect to having sort of a basis for that. There's lots of examples where this can work, right? Like, so AI performing case summaries, physician interacting with the patients, right? Like the AI is terrible at creating having that interaction, that physical interaction with that human. It's really good at taking the content of that interaction and creating a summary or some sort of structured note that comes out from it. So again, the research and the literature on this is still unsettled, but these are sort of questions to be thought about when we think of what is the human AI collaboration within this process. I'll take one example in a little more further down the road, so to speak. The AI scribes, I do not know the extent in which the folks here have used these sort of scribes. The ambient AI scribe basically records conversations in a physician-patient encounter, creates a note in a SOAP format. There's 20 vendors that are out there. It's a great example, right? Like it's actually separating out this sort of role separation framework where the physician it does the harder part of creating an assessment and plan for the patients in front of them and summarizing that, and can focus on the patient. And the interaction is much more streamlined in that. But the physician still has the role or reduced role of actually creating the summary, reviewing the note and creating the summary. So these sort of tools are going to come. It's going to change from, ambient listening to ambient interactions to, I don't know, ambient video. So these frameworks within the clinical setting are potentially going to change. So the sort of the last two ones that I wanted to talk about is mostly related to my research. So this is really where I have spent a lot of my time thinking about where both in my operational role and in my research in my researcher development role, what is the role of AI models that are developed by researchers versus sort of the buy versus build, and sort of the argument that I've generally made is that researcher models are rarely implemented, but vendor developed implemented models are rarely researched. And this sort of these extremes are really what you would see, especially in an academic medical center. I'll take a couple of examples to take the first part of that statement that I just said, which is the second part of the statement, which is vendor developed implemented models are rarely researched. I don't know how many of you have seen the EPIC sepsis model, which was implemented around 2018, 2019. So just to give you a background, EPIC developed a sepsis prediction model called ESM. And they said, hey, it works. And they told their vendors, their customers said, hey, just basically download it and use it. It'll predict approximately several hours before when a patient's going to develop sepsis. Here's the problem. It had a reported AUROC of 0.8, and they were just told that it was trained with the penalized logistic regression. The only problem was that the model didn't really work. So Karandeep Singh, that was the paper there, and was in JAMA Internal Medicine several years ago. Essentially, the model's performance was way lower than what was expected. Karandeep and others in Michigan ran this big study. It generated alerts on 18% of all hospitalization, identified only 7% of the patients that were missed by the clinician. Epic ended with egg on its face, pull the model, revise the model, put it out there again. So everybody's now very skeptical of these sort of models that are put in there, mostly because they come as black boxes. So this is just one example, right? Like this study was actually also replicated in 9 other academic medical centers. Results were essentially same. It's the model poorly predicts sepsis, right? And again, this was many years ago. Still, fundamentally, the argument about these sort of models. Like, let me take another example. I started with the example of ambient scribes, right? There's 15 products. Like I said, there's 15 products. The market is essentially helps a physician reduce his note writing time, which is great. And then there are questions. Are there questions about the quality of the note? Those sort of things we're still evolving. But if you look at the studies, there's about over 200 studies that have been published on various. This is just a sampling of some of these. What you would find across the board is that now there are 2 trials, but how do they work? Do they really work? Is there a time benefit? And I didn't put those papers in here, but there were 2 trials that were published on ambient scribes, and essentially the results were contradictory and marginal improvements in actually note writing time. So the question really then becomes, are they productively tools? Do they reduce the work effort that's needed by physicians? Definitely does. So again, it goes back to the argument that before even a trial was done, before even the numbers would come out, academic institutions across the country have spent millions of dollars. An average installation costs somewhere between, depending on the size of the institution, between $3 million and $15 million. So these sort of investments are happening, but the evidence base that actually supports, besides the fact that it is useful, there's no question about it, is something that we all should look up. So again, most of these vendor developed models, and I've dealt with probably 20, 30 of these vendor developed models. Most of them actually don't really provide have the promise that they have that they've advertised. They lack transparency often. Several of them go under, mostly with startups, and then we get no support. So I'm happy to talk about all sorts of applications on that spectrum. But what I really wanted to talk today was mostly around my research, which is essentially the idea that researcher-developed models are rarely implemented. The question is why? And I'll throw an example or two just to show the difficulty and the sort of challenges around that. So if you think of what is needed for a research model to be implemented, so if you take this as sort of the general cycle that's needed, I go from a needs assessment to essentially putting it within a health system. In between, there's model development, lots of validation, and sort of implementing within the EHR. But if you look at the last 8 to 10 years, and I've been a machine learning data scientist for about 10 years now, most of the work sort of stays in that model development and local validation, publish a paper, and we end there, basically. Irrespective of the clinical problem that you're trying to solve or look at, I can almost guarantee, don't want to guarantee, I can almost be certain that there is a paper that's published in that space right now. So the question really is, we're just model building and then sort of let it die. So what does it need to, what do we need to move beyond the model building and try to take it to the point of care and potential benefits? Or essentially, how do you take it through the entire spectrum of this set? I've sort of two case studies. I'll probably just stick to one. Both are from my current and former trainees, both on K right now. I'll start with the first one, which is predicting the risk of surgical transfusion. So surgical transfusion, Sunny Liu, she's an assistant professor in cardiac anesthesiology here. She's my trainee through her postdoc years and now K. So I'll pause here for a second, but just wanted to see if there are questions that could potentially.
Still David's question, which I think we can is a great question, but we can save for the end as more general.
Okay, I can answer that if it's needed.
Sure, yeah. If I'll read it and then David can jump in. He says, as physicians, we used to not know how to write anything, let alone notes. Then EHRs came and we got a bunch of copy paste trash, and now we have AI slop. Maybe ambient listening will bring us back to bring us back to physicians not knowing how to write, which I'm not sure makes you a bad doctor, which is a really good point.
Yep.
Writing not being an innate skill for anybody, I think, as we all learn as we get older and become professionals. And our writing has long been ineligible. He cracks a joke about doctors on script pads and things like that. But actually being able to listen to our patients and focus on clinical reasoning and bedside manner instead of feeding the digital beast, which I think is a great question.
Yeah, and I 100% agree with that, right? Like I think that's the purpose of these sort of tools, right? Like bringing back to the joy in medicine, joy in practice, and potentially reducing the effort that's unnecessary in supporting things that are specifically for other purposes, billing, insurance, those sort of things. So 100% agree. I'm not questioning any of those things. All I was saying with all of those examples was that there is still a lot we do not know about these tools that we're bringing to the point of care, and it may have unintended consequences that we still do not know what the implications long term are, and there may not be any, but it's worth our time and effort to look at. And the NIH is also I want to say spending a lot of money in that space currently right now, or attempting to, for what NIH is spending in that space. So I 100% agree with David. All right, I'll get back to this. So this I don't know if there are any surgeons or anesthesiologists in the room, or essentially blood is often required for surgery, and the idea is that the preparation process for blood, if you order it at the last minute, it usually takes about an hour or so. Essentially, you have to identify the blood type, find the number of units you need, and it needs to be delivered sort of in an emergency fashion into the OR. What happens is that in order to avoid the sort of emergency ordering, a type and screen of the blood is performed usually during a preoperative visit, especially for major surgeries. The problem is that over 50% of the 50% of the cases, and in a big academic medical center like ours, it has over 100,000 surgeries. 50% have pre-surgical blood orders, and less than 10% actually require them. So what happens? It leads to RBC, red blood cell waste, an inefficient way in which to run in terms of costs. So the traditional method is sort of like a table. It's procedure specific. Here's a procedure. A coronary bypass, a type and cross, we need 4 units of blood, and then that's how you essentially look through a list and do it. The model's nothing fancy. This was done several years ago, about 4 years ago, which is part of the point I wanted to make in a broader scale. Sunny developed a personalized risk prediction framework, and essentially the idea was that it took into patient characteristics, developed a personalized model that'll predict which person would require blood during surgery. And the focus of this model was not to predict blood during surgery, but the fact that whether you need a type and screen order prior to surgery, such that you can reduce the number of type and screen orders. Um, we did a needs assessment, just like you would in our preoperative clinics. Very significant support for like significant arguments were made that the decision-making process was fairly arbitrary and inconsistent. So some sort of mechanistic way in which we can provide this was had incredible support. Um, Again, like I said, not to go into the model development part, we built the model, had really good performance, as an AOROC of I want to say 0.93, with a gradient boosted machine, nothing fancy. This model was built using the National Surgical Quality Improvement Program, NSQIP, a large database with 3 million patients. Paper was published this is 2022 if I remember right, so several years ago. We did a validation of this with a broader cohort with 4 million patients. Again, consistently high performing, even across not just our hospital, across 414 hospitals. We also, again, did a third validation study with a third cohort, which is over 45 hospitals. The challenge with NSQIP is that it doesn't have all the data associated with all hospitals. It's a subset, very curated set. So wanted to do it if we said like everybody in a hospital. So that's the multi-center perioperative outcomes group cohort, which is based out of Michigan. We had like 60 hospitals that provide data. Again, incredibly consistent performance across, not just across one site, but across all the sites with a what the most interesting part, like for us, was the significantly tight confidence interval in the model performance. Again, the model performed exceedingly well without any association with the hospital type or the type of hospital or hospital characteristics. And essentially, the idea based on the model versus the MS-BOSS comparison, this is 17% decrease in the type and screen orders, and the cost of a type and screen can range anywhere between $17 and $400, depending on the insurance, bookended by our insurance, how the insurance, the healthcare insurance in the United States works. That's the paper. This was recently published, I want to say last year. 45 hospitals. To the best of my knowledge, this is probably one of the larger multi-hospital at the individual hospital level study on these sort of models. So again, the point was not to talk about the modeling purpose, but mostly in terms of what did it take, right? Like just to get a researcher developed model to say, hey, this works, and this really works, and this really, really works, sort of argument. So we went from a needs assessment to a model development to really validating it so that we could convince at least our internal operations to say, hey, we can implement this and do this. So this is essentially 2.5, almost 3 years of work, basically, to get to this point. And then I'm going to skip this. If I don't know if folks here are on Epic or not, we have the compute platform. We have it fairly well set up. This was sort of the first model that we implemented it within Epic with sort of we had lots of design considerations that we considered. This is how, I mean, if you're familiar with Epic, it was in the navigator pane. You can see, it's single number, which shows a risk associated with that patient, whether to order a type and screen. Ran some lots of usability evaluation and prototyping, created a manual of sorts around that, implemented it, had factors associated with it. This was at the discretion of the nurse practitioner or the resident who was making those decisions in the pre-op visit. So here we are. We're at 3+ years, still starting at the 3.5 years or so, still starting at the point of no clinical trial. We don't know if people are going to use it, still don't know if it's going to work. We have our silent validation done where we started the cluster randomized trial on October 1. We're active, so the study will be done almost towards the end of this in November. There's lots of issues to be discussed. Primarily, what I wanted to say in the time that this model was implemented, several other papers have also been published. So we're going to come up with this very solid, robust, empirically validated model along with a clinical trial. Doesn't mean that it's going to be the standard practice of a model across institutions, because at this point, I mean, this is again my 2 cents with implementing these sort of models. All models are local, no matter how you think about. All models are local within the institution. I mean, there might be generalizable things that you learn about how to implement it and how to use it, but fundamentally, institutions are either going to buy or build their own models from a researcher's standpoint. So, lots of lessons learned with this. So I'll be happy to. We're hoping we can publish the results from the trial at some point in the next year. But again, it was a learning experience in terms of doing this. So research, as I said, research developed models are rarely implemented. So what makes it difficult? There's always Taylor Swift in her lyrics, which will give you answers to almost any problem. The biggest challenges are really related to not having data pipelines which are integrated in Epic in scalable ways that models can be easily tried. Even when they exist, they're expensive to manage and maintain, and there's a lot of the setup is currently held by what I would call band-aids in terms of implementation. There's also changing standards with respect to platform. That no standard platforms exist. I can get deep into the intricacies of how Epic manages its platforms for implementation of these sort of tools. It's consistently changing. And there's also a lot of institutional inertia on and regulatory things to be considered when we try to implement these tools in sort of a research setting, not in an operational setting like using scribes or things like that. There's also fundamentally very serious questions to be answered about, like, which I raised earlier about, is it a human AI collaboration versus a role separation sort of framework? How the interface is supposed to be designed, alert timing, delivery, how to adapt models for people with different experience and expertise, right? Like these are things that we still don't know the answers to. And sort of the regulatory and ethical questions around implementing these studies or implementing these models at the point of care, it just vary from institution to institution. And this is probably where cross-CTSA collaborations could potentially help. So again, what you also, even if you go across this sort of framework that I described, there's still challenges, right? RCTs are expensive. Is it possible to run RCTs for every single model that people are developing and bring into the point of care? It's just not possible. So there are questions about what are sort of alternative mechanisms to think about these sort of problems. How do we think about faster life cycles for development and evaluation, more than development, evaluation of these models? Because I think personally, the sort of the locus of control for innovation, especially in large language models, has now been lost from academic medical centers to third parties and companies. So where we have potentially the biggest impact is that translational phase, and how do we think about life cycles of AI models? So with that, I talked very broadly about sort of 6 ideas, aphorisms, broadly, I would say, and how we think, and it is, at least to me, these are important considerations when you think about technology, and how we think about these things within this context makes a lot of difference. I'll pause there. Got about 10 minutes or so. I'm happy to take any questions.
Yeah, Courtney wrote in and said, would love to know more about the governance and processes at your institution to integrate these models within your electronic health records.
Yeah. So I created the governance structure, so I can tell you the sort of the structural sort of challenges within that. So do you want to know the process, or do you want to know how I mean, in terms of setting up, or do you want to know about the process?
So let me tell you my bias. I am on the IT side and I am tasked with helping to figure out how we're going to meet the ever expanding needs of our researchers who are all clamoring for this.
Yeah.
And so anything you can share with me that would help
Yeah,
me, we're
I'm
hitting.
happy to. Yeah, maybe this is probably an offline conversation on a longer scale.
Okay.
But right, like so, our process works two ways. So first, you're talking only about research and developed models on
Yes,
governance, right?
exactly.
Not the vendor.
I'm
That
talking
has a
about
different.
researcher developed. Researcher developed. They come, they have ideas, they want to integrate with the EHR. They're hitting a lot of roadblocks. Like, should we let them? What do we have to do? How are we going to decide which ones we should do? How do we phase them out? All of these types of issues.
Yeah. So we have what's called a clinical informatics research committee, which has the CMIO, the a couple of other leadership and a set of physicians in that group. And so the purpose of that committee is essentially yay or nay in terms of the idea, in terms of implementing. So if that goes forward, then it faces the biggest roadblock of all is how to build it, right? Um, Most often, it's some of it's people might come with an NIH funded idea. If it's we currently are out of money in terms of actually building things for people. So, for example, a custom implementation of an AI tool within Epic Cognitive Compute platform is out of scope at this point. So if it is a Firebase implementation, there's a cost associated. We essentially go somewhere to a third party with a bill with an invoice to the investigator, and most often it stops there. Said this is too expensive. It needs a new HL7 feed. There's questions about what needs to go in there and things like that. So there's that. Let's say that all of that's overcome and they're ready to build, and they have the money and they have the support. Then we do two things. One, we ask them to go through the IRB process. The IRB leads are actually part of the clinical informatics research, the governance committee. So the conversation has already started there. They submit a full protocol, and then at that point, at that point, there is the discussion of consent considerations. I want to say we're a forward-thinking institution in terms of these sort of tools bringing to the point of care, but there's always concerns. There's security concerns. There's security concerns. There's legal and compliance concerns. So there are these sort of things. We almost always require, if it's an investigator-initiated project, that there's a DSMB, Data Safety Monitoring Board, along with secondary reporting to our governance structure in terms of changes. I might have missed a lot of things in between, but again, it's a traumatic process. As somebody this is the project that I talked about. The surgical transfusion risk was the first one that went all the way into a trial, and it took 5 years to the trial to start. So for 5 years loosely, you can say the first 3 years were research development, so 2 years, and it's a long time.
Yeah. Okay. I appreciate that. Thank you so much.
Got a lot of more questions coming in. Bob writes, could you talk about approaches to validation that could be used instead of RCT? Specifically, what is the drawback of these shortcut methods?
Yeah, 100%. So I think I think RCTs are from a financial standpoint impossible to do with these sort of models. I 100% agree. So the model that I would say is that we actually tried with our ambient implementation is what I would call a quasi-experimental design, sort of looking at changes after a certain time point, assuming intent to treat type of an analysis, right? I can put a link to a paper that we did. like an interrupted time series type of framework, where it's really not possible to randomize in certain situations. And those sort of somewhere between the quality improvement and quality improvement and research is probably a discussion that needs to be closely had with the institutional review board. I will tell you, I've spent several meetings with our Human Subjects Research Protection Office on how do we think about these sort of problems, right? Like in terms of researchers clamoring for their models to be implemented, some of it's not research. They just want to improve their care outcomes or care predictions, or that can help them in their process. So absolutely, this question of how do we think of alternative frameworks for study designs is relevant. Which also brings me back to the statement that I made earlier, which is all models are local, right? Like you're not trying to come up with generalizable knowledge about generalizable publication in JAMA, because the technologies, by the time you get the trial done, the technology's already moved on. And I'll give you a simple example of my own clinical trial, which is funded by NIMH, and I didn't talk about that today. So we built an AI coach using Alexa in 2020. I was funded by NIMH in a mechanistic study. It had some machine learning in it, nothing fancy. We ran a phase 1 trial that was published, a phase 2 trial that is soon to be published. I can't say out loud where it is. But now the tool's obsolete, right? Like it didn't have large language models. So now we're back to square one, trying to rebuild these sort of tools within a completely different environment and a framework. That I don't know. I think our basic scientific principles about whether an AI coach can lead to improvements in both depression and anxiety outcomes is yes, but does it work with the new sort of the intervention is going to change because of large language models. So this question of going back, this question of how to think about these trials also is an important consideration. I don't know if I answered the question. It's a complex question. Bobby, you're muted. Robbie, you're muted.
It is a complex question, and we have a few others and are running out of time. Oh, great. Okay, so the poll is up. I just saw. Please take a second to answer that poll. I will just let you know, because I know people are dropping off, and then maybe we can get into one or two more questions. Our next Grand Rounds is April 20th at 3 p.m. The link I can drop in the chat as well. And that is with Dr. John Bell, and it's about the ENACT Concierge Clinical Evidence Service, which is a service we offer. You can write in with specific questions, and we'll get back to you in a business day or two just to help with that, setup and any other technical questions people might have. Bear with me, and I am going to get back to the questions. If you have a second, Thomas, to answer one or two.
I do. I'm fine.
Okay.
I can stay a couple of minutes after.
Great. And Tom Hopton just put the registration link in. Shirley asked a really good question with a lot of context that I'll condense a little bit. And I have a similar issue. So she describes that her and her husband have received a number of diagnoses where side effects or other effects were not recorded as typical, and told, that's probably not related to your medication, and now is getting more intel as she goes in with her PCP and feels validated and seen, because she believes that they're using AI to glean other information, maybe more marginal effects of these medications or conditions. And I'll just reveal myself. I have an autoimmune disease and agree with Shirley. It seems like the breadth that PCPs or even specialists can get with their almost like research in the room with you is improved. So
yeah, no,
I thought that was an
100% 100% agree with that. I mean, I think the expanded bandwidth, when you don't have to focus your mental and energy on something of listening and typing a note, and also having the tools at your disposal, which is much quicker than UpToDate or some of the older tools that are there. It's just phenomenal, right? Like, I mean, there's no question that the practice of medicine is going to improve by that. by these sort of things. There's no question about it.
Rob, you're muted again.
Yes.
Strange. Sorry. Guy writes in and says, how challenging and expensive is it to harmonize EHR-based models for more general use by other cohorts of patients? And I'll just mention, the ENACT network does a data quality initiative to try to at least harmonize or standardize some of the terms being used. But Thomas, maybe you can answer that a little more in depth.
Yeah, I don't know the answer to that question, right? Like I think the way of the future in avoiding these multi-step ways in which we can validate the models, you heard my example, right? Like it took several steps and several data sets, and the real question is, can you rely on these multi-center cohorts of data, and can you create a sandbox environment where people can plug and play their models in these large networks is really a question to be answered, right? Like, and
Yeah.
you see what I mean?
I do, but another question is, if you make any model based on EHR data cohort, how biased is that? Because already you have patients who are already seen by a physician to have an EHR record.
100%.
So that anything you do a predictive model based on that
has its own set of
intrinsically
issues.
biased. Is there a way out of that?
Unfortunately, in the modern, that is the basis of most of the how the models are created. So I'll give you an example. Recently, a company from Israel had a predictive model for ARDS that they were trying to sell to us at our institution, and it just doesn't work here. It just like really doesn't work here, right? Like the patient cohort's different. It just doesn't, right? Like, so these sort of biases are important for us to see that there are there generalizable models? I mean, there are models that are functionally generalizable. Are they practically generalizable is really a question to be answered. And I do think that with EHRs expanding almost, at least in the United States, to the extent that they're available at most practices at this point, some of that issues will be solved, but then there's care access and interoperability and questions around that.
Thank you.
Great. And then, one more real question. David had a lot of great other follow-up comments, but Rebecca asks, it seems that that commercialization of ML, I believe machine learning models is the goal. Create them, then get them back into EMR as provider decision support tool. Because of the difficulty of validating nationally, would you say that the product should be a ML workflow that is trained on local data at hospitals across the country instead of one model that is supposed to work everywhere? That's interesting.
Yeah, I agree.
Mm-hmm.
It's not really it's really a model that works here at WashU or Pitt, and then say this is our framework in the delivery process, and then that becomes the framework for you to use. But again, from a commercial standpoint, if you're selling this to a rural hospital, they'll say we don't have the resources to train a new model and test this before we get it in there, and that's the fundamental challenge for these sort of things. That's why these vendors come and tell you we have a model, just plug and play, and it really doesn't work in most cases.
Mm-hmm. And then David kind of finishes us off here. It says, just as great talk, thanks. And as a cherry on top, can you tell us the future? What innovations are you aware of that might be coming to EHRs and adjacent tools in the next 18 months or so? And then he follows up with, any chance we'll find a way to stop overfitting our models?
I think that's been an age-old problem of overfitting. I saw that and I was like, yeah, I wish we could solve that. But I think in terms of the future, right? I think in terms of future, there are going to be all of these tools that are going to come to the point of care, and it's all going to be from big third-party companies. There's going to be tools for summarization. There's going to be tools for integrating multiple data streams such that physicians can reduce the time that's required in order to aggregate data from multiple sources. It's going to be better ways for clinical documentation, revenue cycle management. So there is going to be a lot of these efficiency related, quality related tools, at least in this I'm just talking in the next 12 to 18 months. And it's all going to be big money, expensive. And I think this is another phase in which the wealthy, rich hospitals or wealthier hospitals will make these changes, and the smaller hospitals are not going to be able to keep up with the changes that are coming. So that's another sort of plus and minus that's going to happen. But again, I still don't see, maybe except in maybe imaging, pathology, radiology, in terms of practice of clinical medicine, the development and implementation of CDS, clinical decision support tools, are still a little away for a number of reasons, both ethical and also compliance and legal issues. But efficiency related tools, summarization, documentation, coding, all of those tools are just coming at us fast. And once again, I want to thank everybody for coming to the talk and also having me present today. I really appreciate it.
Thank you so much for coming. We appreciate it. We're a little bit over, so thank everybody for your patience. But please join us April 20th if you have the opportunity. Appreciate it. Thanks so much, Thomas. See you all soon.